What we're going to go over today is range of motion in supine. First thing, when you get into a room and you're going to do range of motion with a patient, make sure that you get the bed height high enough for you that's comfortable so you're not hurting your back. Because sometimes the limbs get heavy and it's difficult to keep good body mechanics. What we're talking about when we're talking about range of motion, we're talking about moving each joint within their available range. The difference between passive is where you are going to be doing all of the work. The patient may be sedated, intubated, and you can't. They can't assist you in the range of motion. So passive range of motion is where you'll be doing all of the work. Active assistive range of motion is, say someone has had a stroke and they're limited in their amount of active movement. That way you will assist them through the range of motion, but they're doing part of the work. Okay, so that's the active assistive. The active range of motion is you're just basically guiding the patient, telling them what to do, and they will do it on their own. It's active, total patient effort. Okay. Hip goes through flexion. Okay. Abduction and adduction. Abduction is this way. Adduction is towards the body. Okay. The hip also rolls in and out. Okay. It's a ball and socket. Okay. So those are, and it goes in extension. But if we're in supine, we're not going to be doing extension. So those are the motions of that. The knee, it's a hinge, so it only basically just goes, it flexes and extends. That's the only motion that the knee does. Okay. The ankle is a little more difficult. It's a little different, but for our purposes, for tech purposes, you're going to basically think of up and down and maybe in and out. Okay. So the ankle goes up and down, and then it inverts and everts. Okay. And sometimes people will do circles. That's fine, just to get the motion of the ankle. Okay. So when you're, say we're passively doing range of motion, or if you're assisting the patient, I always put one hand up under the thigh. I usually hang onto the heel or the foot. Okay. Put it up under the knee. So when we're going up, you're going to move your hand up, and then as you come down, you're going to go down. Okay. That way you can help control the patient through the whole range. On really heavy patients, you really make sure the bed's up high enough. You might have to get a wider stance, and you might have to really get your body into it, up and down. Okay? So you take them through 10, 15, 20 repetitions, whatever the therapist asks you to do. Okay? When we're going to do abduction and adduction, sometimes I'll use here, it depends on how much they can assist you. If it's mainly passive, I'll probably do it from the inside of the thigh in. Or you can do it this way. Sometimes it's hard to get them to, if they can help, it's easier. You can kind of pull them a little bit. But it's hard to do totally passive sometimes if it's a large leg, especially, to get it out and in. So sometimes you can put your hand here or under here. Okay, that's abduction and adduction. Now on the hip internal and external rotation, what I'll do, it depends. Now if they're a total joint, we're not doing excessive internal rotation. We usually won't do that for total joints. But on a regular general medical patient, we're going to do internal external rotation. When I do that is I cup my hands around the kneecap. I don't want any hands on top of the kneecap. But I usually cup it around so you get in hold of the bottom half and the top half, and then I roll it in and roll out. Okay? Just internal rotation. You relax and let me do it there. And external rotation. Okay? Another way to do the internal and external rotation is in a flex position. You can do external and internal rotation. Okay. The one thing, the external rotation, of course, is going to be a lot more range of motion. Internal rotation, it does not go that far, okay? Just anatomically, it will not allow you to go that far in, okay? But we also can, you can incorporate, we incorporated the knee flexion extension also with that. So we did that and got the knee flexion with it. Okay, with the ankle, I showed you before, is dorsiflexion, which is pulling the foot up, and plantar flexion. Okay, now the foot, again, anatomically will not go, it'll go maybe, relax. It will go a little ways past 0 this way. But this way you have a lot more range of motion, okay? So you do the dorsiflexion, plantar flexion, okay? And then you can, usually what I'll do is I'll cup the heel to do inversion, eversion, okay? Inversion, eversion, got it? Okay. Also, what we'll do, it's part of the range of motion, it's just a stretching. Because people, when they're sedated or comatose or anything for a long period of time, when we normally are in bed a lot, we have a tendency, when we relax, our feet get plantar flexed. And then we lose the calf muscle tightens up and we lose some of that range of motion this way, okay? So what we do is heel cord stretching, okay? And what that is we're just stretching the calf and the heel cord, the Achilles tendon. Let me show you here. What I will do is I cup the heel again, and I use my forearm. Stabilize here on the end of the tibia, and then kind of lean forward into it and stretch. You feel it? Okay? And then hold it for about 30 seconds or so. And then relax it, okay? Because if we can't get at least to 0 when we are ready to start mobilizing and they stand up, if they're contracted in that position, they're going to fall backward. They're not going to be able to stand up upright, okay?